Okay, so 12 lead EKG. This is basic 12 lead EKG lead interpretation. Again, you have to know your normal stuff, what your normal P wave looks like, PR, QRS, QT, all the things that are normal. And then we'll talk about some of the abnormals. Of course, we'll be focusing on the ST segment and the T wave. Those are kind of our go-to ones we're going to be looking at. Okay, what? You've seen those intervals before? This is from a monitoring company, so that uses AI to figure out if there is a change in ST segment or T wave amplitude or P wave amplitude, P wave area under the curve. It assesses that well before a human ever could. All right, so it says, hey, you got a 10% change in your ST segment, or you got your PR is getting prolonged. It would then output that for you. So that's the nice thing about that. Okay, so anatomy of the 12 leads, we'll look at, you get a 12 lead paper in front of you. What am I looking for? How is it laid out and such? Leads and axis, we'll just only get an introduction to it. We're not going to really pay too much attention to axis because that's a little more when you get to talk about 12 leads. And then the emphasis again is AMI or acute MI or ACS, right? Looking at ST changes, whether it's an STD or an STE, right? ST depression or ST elevation. And then T wave versions. Is it a T wave that is biphasic? Is it a T wave that goes up then down or down then up? Right? So a T wave that goes up then down is actually much, much worse than one that goes down then up. And we'll kind of point those out, what that looks like. And then finally, after putting all that together, now it's like 3 or 4 different layers you got to kind of think about at the same time. It's like, hey, here's the 12 lead changes. Oh, what does that 12 lead feed? That feeds the inferior wall. Oh, shoot. What vessel feeds the inferior wall? Oh, that's the RCA. So that's how you get to what vessel they have to get intervened upon within 90 minutes, right? Because they, oh, I guess we got it wrong. Let's go to the other side, right? So they want to make sure they're going to the right place at the right time. All right, so that's the idea behind 12 leads, is to figure out what vessel is being occluded at this time. We're going to have an occlusive MI or a obstructive MI, all right? It's the coronary anatomy and the geography, which leads, like 2-3 AVF or 1 AVL or V5, V6 or V1 through V4, which one of these patterns looks at a specific part of the heart. Okay, so the process here is kind of the same process you do with arrhythmias. You're looking at arrhythmias, you're looking at the strip, you look at the rate, the rhythm, P waves, QRSs, all those things. That's all basic. And then now we are looking at, on top of that, what is the 12 lead going to give us, right? So rate, rhythm, yeah, you can use the 300 method, like I think we've discussed before, right? So you can, each one of these lines, if you do all the maths out, and you can assess if they have elevated heart rate or low heart rate, right? So if the QRS complex was right here, that heart rate would be 150, right? This heart rate is right here, so it's a heart rate between 60 and 75. So that tells you how fast it's going. A faster heart rate is never good for an MI. That's always usually a bad outcome, as it puts a lot more stress on the heart. So we want to get that under control. Beta blocker can help that, right? And then what else? What's the rhythm? So that's where we use all of our arrhythmia interpretation skills to figure out what rhythm it is, right? Is it a first degree block? Do they have ectopy? Do they have VTAC? Do they have AFib RVR? Do they have SVT? And we'll touch base on this, I think, in our next lecture when we talk about arrhythmias and more advanced arrhythmia recognition. But what is the actual rhythm? Is the QRS prolonged, right? Is the QT prolonged? Those are things we'll talk about next time. And then the intervals. Are all the intervals good or not good? And the intervals we're going to focus on the values we're going to look at most frequently are going to be our little Q wave right there. And you have to know that a Q wave is part of a QRS complex. And then morphology, we have upright or inverted structures. Inverted structure that we're paying attention to is the T wave. Is the T wave inverted or not? When the T wave is inverted, that usually means that I have ischemia happening, right? It's usually end-stemming. So other things we look at is, do they have a peak T wave, right? Peak T wave, you think hyperkalemia, but if it's a narrow peak T wave, yeah, hyperkalemia. If it's a wide peak T wave, then it's a MI that you have on your hands, right? And we'll point that out when we talk about T waves. And then also symmetry. So a normal T wave has what kind of symmetry to it? Is it symmetrical or asymmetrical? It's asymmetrical. So you can see, notice this T wave right here, how it looks different on both sides. If you have symmetrical T waves, that's a problem. All right, there's something going on. There's something pathologic happening. Okay, and then finally, when we do our normal process, like you look at any EKG, looking at rate, rhythm, axis, intervals, morphology. Here we're looking. That's our focus today. Is there ischemia or infarct occurring in front of us, right? And remember, STEMI is an ST elevation. The most common cause of that is not the most common cause of ST elevation is not MIs. It's actually number 8 on the list, right? It's not even up there. So these are causes of ST elevation that is not an MI, right? You got a left ventricular hypertrophy, you got a left bundle branch block, you got a paced rhythm, you have pericarditis causes ST elevation, you got early repolarization, which we'll mention briefly. You got ventricular aneurysm, which we'll touch on more when we talk about MI complications. Hyperkalemia can cause it. Brugada can do it. That's a rare genetic thing. But all these things you can see could cause ST elevation. But it wasn't the heart. That wasn't a obstructive or a lack of flow to the heart that did it. It was something else that happened. So the big thing about 12 leads is always look at the patient, correlate with the history and presentation, right? If they have ST elevation and like a 27-year-old, it's like, well, what's going on? Did they take cocaine? Or what happened, right? Why does he have ST elevation? Usually in a young kid, it's probably gonna be like a benign early repolarization of some sort, right? It could be valve disease, or it could be something else going on. So we got to look at it, kind of correlate with the history as well. And look at the previous 12 lead. Having a baseline is going to give you a lot of information. Like one you see ST changes and the other one you don't, right? So they have new ST changes, that's a problem, right? And again, everyone gets a 12 lead on arrival to the ER. If they don't, then they need to get one in the ICU. Okay, so that's the idea behind looking at our 12 leads. And yeah, we'll kind of touch base on access just briefly, but these degrees here about why this is up there, why that's down there, we'll kind of touch base on why that happens, but you just basically have to memorize that that's where they are at, because it will tell us that, hey, if I have problems in 2-3 AVF, you can see that's looking at the bottom of the heart or the inferior portion of the heart. Like why 2 is down there is not as important as that it is down there, right? Because it's just physics, and that's the only way to explain why it's there, right? There's no other logical reason. Okay, so that's how they can. And then when we look at the axis, we should have most of our electrical activity going down and to the left, right? Because that's the left ventricle is big, so a lot of electrical activity going into that left ventricle. And if it's different, that means something might be happening. All right, so the anatomy of a 12 lead. So printouts are standard. Isn't like different machines print out a different kind of 12 lead, which is nice, right? They all are standardized. In the upper top left corner are demographics in green here, right? As demographics, it has your intervals and it measures, right? It's pretty accurate. It's not, you can't, these things you can trust. The interpretation, that is dubious. You got to search your feelings to know that it's true or not, right? It's hard to say that that is accurate. So that requires some human intervention. It has a lot of algorithms that it can try to figure it out for you. And you can say, oh yeah, that is a right bundle branch block and a right vesicular block and all that. You could get there with it, but you need to look at, oh, I do see ST changes. I don't have CST changes. Right, so this information in green is accurate. And again, the axis, normal is in pink there. It can tell you, it'll give you a little degree output to say, hey, your degree is negative or plus 60. So, well, that's normal, right? And then what else? So it will tell you your limb leads and your precordial leads, or it has your limb leads and precordial leads. So your precordial leads are on the right side of the page, right? So they are on this half of the page. It's your leads that start with V. Those are your precordial or your chest leads, right? It's 3 seconds worth of information you get out of each lead, and each one of these drops down to 12-second strip at the bottom. So you can see what happened here, what happened here, what happened here, what happened here. It's the whole thing separated out, and then they then look at each different section of the heart when we have those leads in place. Okay, so these are our precordial leads or chest leads on the right. They have to be placed properly, otherwise they can miss ST segment changes. So we make sure they are placed properly, and so they could be in the wrong space or they could be on breast tissue, and that can then hide our ST changes or T wave changes. Okay, and then we have on the left side, these are our limb leads, right? So our limb leads are on the left. So these are our 1, 2, 3 AVL, AVF, AVR. I got a screenshot of a note that says lead 4. It's like, whoa, these guys are like making science advancements over here, right? So there's only leads 1, 2, and 3, and then you have these augmented leads right here, AVR, AVF, and AVL. And those ones use even more physics and more amplification to get them. Okay, so these are our limb leads, and they cut the heart in half, right? If you put a heart right here, right, they cut it in half. They're looking at the inferior portion of the heart, or look at the lateral portion of the heart. They don't look through the heart like our precordial leads do, which is nice. or not nice, but it's just another way to look at the heart. All right, so lead placement, as we know, it should be placed properly in the proper spaces. All right, and it can tell you whether you have ST elevation or ST depression. It can be off just by one rib space, can miss it, or it can underestimate it. Right, so we want to make sure they are looking at the correct place in the heart. Okay, so limb leads, so our 1 AVL, our 2, 3 AVF, all these ones are they are based on the placement of the leads on the chest. Our green lead, our black lead, our white lead, and our red lead. Those are all the leads that will get our limb leads, right? They only need to be 10 centimeters from the heart, right? You have some overachievers out there, they'll put on the big toe, right? They'll put it on the big thumb, right? It's like, no, just 10 centimeters, that's all you need, right? That will get an accurate representation of your limb leads, okay? So your black one, your white one, and you can listen to like smoke over fire, whatever gets you accustomed to where it should be placed. And then I have to remember it's white on right, because I was listening to some things. I was like, "Is the white is right?" It's like, no, that's racist. You can't say that. So it's white on the right side, right? That is where you know that it is, that you are above the green lead as well. And our green lead is usually the lead that is for grounding the EKG. So if you see a lot of interference, it's usually the green lead that is as loose. Okay. So yeah, limb leads are they're going to be assessing a frontal view of the heart. It's going to slice the heart in half. So if you're to like peel someone open and cut them in half, it's getting serial killery. But anyways, you're going to be able to see the cross section of the heart, and the inferior portion or the lateral portion is usually what we're looking at. Okay, so those are our limb leads, and those are on the left side of the EKG paper or the right side of the EKG paper? On the left side, right? And then we have the precordial or chest leads, right? And these ones look through the heart. They are looking right through the heart, and we'll kind of picture that, I think, on the next slide. It looks right through from V1, looks right through the heart. Looks at the septum of the heart, for instance, right? So these guys need to be placed where you want them to look exactly, right? Because the limb leads do math and physics to figure it out. Based on the, as long as it's more than 10 centimeters, the math will check out. But these guys are looking exactly where you want it to be looked at, right? So we have our V1 needs to be right here, right? Fourth intercostal space, right sternal border, and then our V2 on the other side. And usually if you're doing EKGs, right, you'll then place V4 next, because that is fifth intercostal space, right? And as midclavicular. And then V3 we just estimate. It's like, right there. And you can kind of put it halfway in between, right? And then what about V5, V6? These ones are on the same horizontal plane. Sometimes they'll say this space, this space, this space. No, it is right across the same horizontal plane. Same thing, fifth intercostal space, and then as a mid axillary, etc., up to the mid axillary line. All right, if people have breast tissue, either way, be male or female, you're going to make sure that it's under the breast, not on top of the breast, because sometimes people get breast enhancements, and breast silicone can impair the electrical signal. So to make sure that it is, it can cause T-wave inversion, right? So to make sure that it is getting accurate assessment of the heart. Okay. So that's the idea of these 12 leads, is make sure the leads are placed properly, so we know that that is actually the inferior leads, or that is actually the septum that it has ST changes, or that is actually V5, V6. All right, so leads and waves. So how do leads work? So leads are positive electrodes, right? The little positive electrodes here, little positive, 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 and they are detecting the movement of electricity in the heart, right? So electricity is usually a wave of depolarization, right? And you get a P wave, you get a wave of depolarization next, which is your QRS complex, and then you get a wave, you get T wave. Why is T wave upright? What the heck? I thought wave of depolarization, right? You can think of it as a positive impulse goes towards my lead right here. That's going to cause it to get kind of like a magnet, right? It's going to go away from it, right? It's a positive deflection. It's two positives are they're going to repel each other, whereas a positive negative are going to attract each other, right? So the idea is if they have you can think of it like a magnet. You can also think of it as very physicsy. So you can think of it like bath water, which is less physicsy, right? So you can think of hot water and cold water. So if I have hot water, right, as my lead, and I add hot water to it, a wave of depolarization, that's going to make my bath water hotter, right? So it gets hotter, right? So that's a wave of depolarization. So my P wave, for instance, is going to go towards a lead. As it depolarizes, my QRS will go towards the lead, and certain leads, depends, but it's going to cause a wave of depolarization if that lead is right over, is seeing that come towards it, okay? And then what about if it's going away from it, right? So that positive impulse is now going away from the lead. That is going to make it negative. You're taking hot water out of your bath. It's going to make it negative, right? So this positive impulse right here went away from my lead, right? That made it negative, all right? And then what about biphasic? What about this situation right here? That's just where it comes and goes. It's like, woo, and just look, woo, woo, right there, whoa. It's the hot water went and then it left, right? So it got warmer and then colder, or it got colder then warmer. Depends how the impulse moved through the heart, right? So you got biphasic, you can have upright positive deflections, or you can have negative deflections. Those are your three possibilities. The other piece is, what if you said, what if positive comes towards us and negative goes away from us? What if negative goes away from a negative? What happens then, right? So that's what happens if a negative force moving towards the electrode, obviously make it negative. But if you have a positive impulse going away from a low electrode, obviously it's going to make it negative. But look, what if we have like a T wave, for instance? Why is a T wave upright, right? It's because, yes, it's a wave of depolarization, but there's some anatomy going on. Because the way your heart depolarizes, it depolarizes from the inside, right? So here's my LV right here. It depolarizes outward, but then it repolarizes inward. And that is a positive, that's a wave of negative deflection going away from it. So it's negative going from a negative is going to make it a positive deflection. So it's just FY, all right? So that's why a T wave would be upright like that. All right, so anything else, though, is going to be biphasic. All right, it just comes and goes. Okay, so you have a positive impulse going away from an electrode, it's going to become negative, right? And we have a positive electrode is positively repelled. It's like, that's too much energy right now. I cannot deal with this. I need more coffee, right? That is a positive. That's a repelling. That's a positive impulse going towards that electrode. So now we need to talk more about the electrodes and how they, where they're placed. Okay. So V1 through V6, these are precordial or they're the limb leads. Which ones are these? They have a V in it. They are precordial, right? So precordial leads, they are looking directly inside the heart. They are like closed circuit TV. They're looking directly at the heart, right? They're looking directly at some kind of piece of the heart, right? So they cut the heart coronally. They cut it in half right there, and they peel it open, and you can see how they're placed, right? So you can see V1 is on the where? Left or right sternal border?
On the right sternum.
Right sternal border. Then we got a little sternum in between there, and then we got the left sternal border, right? So they're sitting right there, and they're closed circuit TV. They're looking directly, the security cameras, looking directly through the heart. And what do you see? You see a septum. That's why they're called septal leads. V1, V2 are your septal leads, as long as they're placed correctly, right? So V1, V2 are placed correctly, right? Right sternal border, left sternal border. Then they are going to look at the sternum. Sorry, look at the septum, right? And why is it like that? Well, your heart is rotated inside your chest, right? So if you take your right ventricle, right, with your right hand, and you put it on your chest, and you put your left hand over it, that is what the space looks like, right? There's a right ventricle, left ventricle. It's sitting like this in your heart, in your chest, not like this, right? It's not sitting upright where it's off to the side. It's rotated to the left a little bit. If you're a really tall person, yeah, the heart can kind of move down a little bit. Someone with COPD, yeah, it might be a little bit different. But a normal placement of the heart is rotated inside the chest, right? So V1, V2, our septal leads, look at the sternum, right? Sorry, I keep saying sternum. Look at the septum of the heart, right? Those are our septal leads. All right, V1, V2 are our septal leads. So if we have septal problems, we're going to see it in V1, V2. All right, V3, V4, if we just keep going along, so V1, V2, and then we're looking at V3, V4. Again, they're looking directly into the heart. Just imagine everything gets peeled away, and now they're looking at what? They're looking at the anterior portion of the heart, all right? So they're looking at the front of the heart. V3, V4 are looking, it's not rotated as beautifully, but they're looking at the front of the heart right there. So those are your anterior leads. Usually V1 through V4, we just say anteroseptal leads because the LAD feeds both of those, right? Both of those areas, the septum and the anterior portion of the heart. So when we have an LAD occlusion, a left anterior descending artery occlusion, we see V1 through V4 changes. All right, so it looks at the anterior wall of the left ventricle. The right ventricle we'll talk about, they got one slide dedicated to the right ventricle. Otherwise, everything else we're talking about is left ventricle right now. All right, and then V5, V6, what are they looking at? They are looking at the lateral wall of the heart, right? They're looking at the lateral, the side of the heart, if you will, right? So one's looking at the front of the heart, one's looking at the side of the heart, and one's looking at the septum of the heart, right? So that's how we are orient when our leads are placed correctly. That's how we know what's going where, okay? And as we know, if there's a positive impulse going towards the lead, it's going to do what? It's going to be upright, right? If you think of like hot water, right? It's going towards it, it's going to go upright, right? So like V1 right here is sitting right there in the right sternal border. You got the first episode that happens in the heart. You have to know heart's electrophysiology. The first thing that happens is that the septum gets depolarized, and then the ventricles get depolarized simultaneously, right? And so we have one happen first, right? So the septum gets depolarized, it goes left to right. That's just how it happens. It goes left to right. So what happens? Little positive deflection right there, right? Little positive deflection in V1 through V2, okay? Because it's right there looking right at the septum. And then what happens next is the ventricles get depolarized. They depolarize simultaneously. And what's a bigger ventricle, left or right? Left. And we look at vectors in physics. When you add vectors together, you add a big vector and another vector going away from it, the big vector is going to win, right? So we have this huge big 2 happen afterwards, right? That's the second episode that happens. So obviously my V1 right here, it went away from it. That's negative, right? Whereas in V6, definitely positive. And look at the little, why is it negative initially? Because it went away from it. V6 is sitting over there. First step, septum got depolarized, went away from it. Second step, this huge impulse going towards me. Okay, so that's the pre-quarter leads and how they operate. Now, what about limb leads, right? So limb leads are, again, as long as they're 10 centimeters away from the heart, it's going to work, right? So you make sure the black is on the right, on the left even, and the white is on the right, right? Make sure those are in the right place. All right, you got a green lead, a red lead, and then you can get all 6 limb leads, right? They don't use closed circuit TV to look at exact place of the heart. You can put them as long as they're 10 centimeters away. You can put them on the forehead if you wanted to, right? It doesn't really matter. It needs to be at least 10 centimeters away, and it uses nice math and physics, right? It's simple, very simple. It uses all this, you know, resistance and ohms and all kinds of other fancy things and amplification to then get a augmented lead or a limb lead out of it. The only purpose to know whether lead 2 is from the lower sternal, you know, down here to like the left foot to the right arm. The only reason why you want to know that is when your monitor calls you, says your lead's off. It's like that's the only reason why that would be useful. Or you're doing your respirations and you could use the monitor to measure, you know, the resistance change. And it's like I don't want to use this one. I want to use the one up top because they're more breathing up top. So that's the only benefit of knowing that lead 1, for instance, is left shoulder to right shoulder. Right? There's no other purpose to this. It's just like cool, like Jeopardy facts, right? That you know which lead is which. As long as it's 10 centimeters from the heart, and it's this, you know, the white is correct and the green is correct and the red is, or the green doesn't matter actually. The red is correct and the black is correct. You're going to get an accurate picture of the heart or accurate EKG of the heart. Okay, so as long as you have that, you're going to get leads 1, 2, and 3. And then you have the augmented leads, which again uses simple math, and it's going to then get you a picture of the heart, right? It's going to get you a axis system. So the augmented leads are going to be looking at this piece of the heart, right? So AVF is going to look down here, AVL is going to look over here, AVR we never care about, so it's cool. It's like a stepchild, we don't care about him until he is important. And it's like, oh shoot, why didn't you tell me? All right, so then we'll talk about that more with pericarditis and left main occlusions. But either way, AVL and AVF are begotten from that. And then also when you have your leads like this, right, you got this, it's called Einthoven's triangle, right? Doesn't have anything to do with Beethoven or Einstein, but it is a triangle that gets formed and cool. Lead 1 is right arm to left arm, but what matters is once you fire it up and you do the EKG, it's going to actually, this lead right here is going to move down to the middle. This lead right here is going to move in as well. This lead is going to move in and intersect, and then you get this over here in the bottom right, right? And this is what you memorize down here. And they are going to come together on the next slide as your axis system, right? That's what tells you which part of the heart it's looking at, right? So we look at 2, 3, and AVF, all look at the bottom portion of the heart, or the inferior portion of the heart. All right, so you can see here at 2, 3 AVF, why did they get there? Doesn't matter, as long as I put it in correctly, it's going to, this is what the axis system looks like. And I can see that 3 looks right there at the inferior portion of the heart, right? And AVF looks there, 2 looks there. So 2, 3 AVF are grouped is one of our groupings that we think about, right? That's usually the grouping I learned first, right? 2, 3 AVF, 2, 3 AVF. It's the bottom left corner of my 12 lead. That grouping right there is its own little thing. It looks at the inferior portion of the heart. I would not include 1 in that because 1 is all the way over here. 1 in AVL look at what? They look at that lateral portion of the heart, right? So 1 in AVL are looking at the lateral portion, right? 2, 3 AVF are looking at the inferior portion of the heart. So those are our 2 groupings we can look at, right? So 1 in AVL are grouping and 2, 3 AVF are grouping. AVR we don't care about, right? So those are all these things came together to form what's called this hexaxial system. It's called hex because it's 6 of them, and it's going to be this axis. So AVR, and we have our AVL, our 1, our 2, 3, and AVF. All these things came together, we added together, and we combined our Einthoven's triangle, and we then got our, that is the yellow slice of the heart, right? It's looking at the inferior portion and the lateral portion. All right, and of course our electricity that goes to the heart goes through it this way, right? It goes through a big left ventricle. And sometimes your left ventricle is more beefy, so there can be a little bit of deviation, right? So that's the normal progression of electricity through the heart, and we can pick that up on the 12 leads, right? And we can see, of course, these are positive complexes because it's going down towards it, right? And yeah, you might get a little bit more biphasic in lead 3 because there's a lot more positivity as we're going towards the left side. Okay, so 2, 3 AVF and 1 AVL are 2 different groupings, and they're anatomical, right? And when we talk about the coronary arteries that feed them, that's the next step to layer on is what vessel feeds my 2, 3 AVF, what vessel feeds my 1 in AVL. Because if I see changes in 1 AVL, it's probably that vessel.
So that's why we see the P wave first, followed by QRS.
So this one just is representing QRSs. So the P waves are not represented here. That's more
the electrical travel.
So your heart's split in half as far as like first your atria depolarized and then your ventricles depolarized. So really we're kind of focused on the ventricles right now. But yeah, you can see on your 12 lead, you can see which atria is larger. You can see in V1 that you're going to see a much higher spike in the first P wave compared to the spike afterwards, because we know it goes from right to left, right? All right, so 12 leads for MRIs. So we're always compared to a previous 12 leads to make sure that we're looking to see if there's any changes, right? EKGs are always in the house, right? I'm not sure how much they charge a patient, but you can always get a 12 lead. No one's going to be upset at you for getting a 12 lead. Sometimes they get upset at you for ordering ABGs, but EKGs are always in the house. You can always, oh, I see something sus, I'm getting a 12 lead. That's perfectly fine. No one's going to fault you for that, okay? And remember, EKGs are only about 60% accurate for an MI. So if a patient has a lot of symptoms, you got to trust the symptoms too, okay? So especially if they have a history, right? And especially if they say, oh, I had the same thing before when I had MI. It's like, well, that's concerning, okay? And ST elevation, ST depression, how do you know it's significant? Well, there's how many millimeters it is, but also there is whether it's looking at the same part of the heart. Like 2, 3 AVF, that looks at the same part of the heart. 1 in AVL looks at the same part of the heart, right? Remember 2, 3 AVF is this little corner over here. I like that corner. I don't know why, but it's like 2, 3 AVF. It's right there in the corner, right? So if I see changes in 2 out of 3 of those leads, that is a problem, right? That is a situation I got to escalate. And leads that look at the same part of the heart are called contiguous, right? So 2 or more contiguous leads, right, with changes is what you could say they have NSTEMI or STEMI happening, right? Obviously, we got ST elevation right here, right? We got ST elevation there and there, 1 AVL. Well, 1 AVL, look at my lateral portion. Those are contiguous. If it was just 1 and 2, that would not be contiguous, right? You can't say that is accurate. And you kind of find out, you go back in the room and there's like leads over the breast tissue and the left and the right were switched. So that's like, well, let's reshoot that EKG, right? That wasn't an accurate assessment. You can always get repeat EKGs as well, okay? So you want to look at the leads, look at the same part of the heart, and if you have changes in 2 or more, right, then that is considered a contiguous leads and something that can tell you if they have an MI happening or not, right? And again, you want to know the coronary anatomy, right? So if we have 2, 3 AVF, have ST elevation there, that's 3 leads. I only need 2 to make it contiguous, and that is a problem. And that is I have something going on, okay? And the coronary anatomy we'll get to, and that's what will tell you that you have a RCA that feeds the 2,3 AVF. That's why I have a elevation here. And there are other reasons as well this could happen. All right, this looks like a posterior wall MI actually. It could be a left circumflex. I don't know. All right, so anyways, we have a ST elevation in most leads. Now that's when we consider it's like yeah, it's 2 or more. It's all 10. So what? It's all 10. What are you talking about? That's like either they're dying in front of you or they have pericarditis. Right? And this is where AVR comes in. Because you look, okay, let's look at AVR. What are you doing up there in the closet or under the stairs? Like, okay, I see you. Come on out. Oh, you're elevated? Oh, that means they might have left main disease. Or if your AVR is depressed, you have pericarditis. All right, so that's the only time where AVR is useful. All right, also you can get symptoms, right? Chest pain that gets better when they sit forward. Well, that feels like pericarditis, right? So this nice 3D graphic kind of puts all that together as well. We got our 2, 3 AVF on the bottom there. We got our 1 AVL up top, and then we have our V1 through V6 looking through the heart at the septum, the anterior wall, and the lateral walls. And sometimes they have separated into low lateral and high lateral. So we have lateral walls over here, V5, V6. Yep, they're looking at the lateral. But which ones look at the high lateral? That's our 1 AVL. They're looking way up top, right? When we split it in half, when we look at our axis system, is looking at the top of the lateral walls, whereas our V5, V6 are kind of a little lower down. I'll point that out.